Hello class, welcome to another lecture. In this video, we will study about pulmonary embolism. How do we define it? Basically, embolism means obstruction of the pulmonary artery by any material, whether it is fat, amniotic fluid, a clot or air. So any material which has originated elsewhere but has travelled into the pulmonary arteries and caused its occlusion can be defined as pulmonary embolism. We are going to focus in this video on pulmonary embolism secondary to a thrombus. Now when this clot manages to reach the right ventricle of the heart, it can travel into the main pulmonary artery and can block the pulmonary artery at any level. Main pulmonary artery, lobar, सेगमेंटल और सब सेगमेंटल. और पेशेंट किन साइन और सिम्टम्स से प्रेजेंट करता है ये डिपेंड करता है कि ब्लॉकेज है कहाँ. तो अगर मेन पल्मोनरी आर्टरी में ब्लॉकेज है तो राइट वेंट्रिकुलर आउटफ्लो जो है वो हमारा कम हो जाएगा. जब राइट वेंट्रिकुलर आउटफ्लो कम हो जाता है बीपी फॉल करेगा एंड पेशेंट विद प्रेजेंट विद हाइपोटेंशन, सिनकोप एंड हाइपोक्सिया. बिकॉज यहाँ से परफ्यूजन कम हो गया है तो ऑक्सीजन डाउन जाएगा, बीपी डाउन जाएगा और सिनकोप भी हो सकता है. ऑन दी अदर हैंड अगर ये क्लॉट किसी पेरिफेरल आर्टरी को जाके ऑब्स्ट्रक्ट कर रहा है, ऐसे सिचुएशन में क्या होगा, जो उस पर्टिकुलर एरिया ऑफ द लंग है उसका ब्लड सप्लाई कम हो जाएगा और लंग इन्फेक्शन होगा. लंग इन्फेक्शन होगा, ओवरलाइंग प्लूरा भी अफेक्ट होगी. इस सिचुएशन में सिम्टम्स क्या आएंगे, चेस्ट पेन. ये चेस्ट पेन किस टाइप का होगा, प्लूराइटिक. प्लूराइटिक चेस्ट पेन के क्या फीचर्स है, चेस्ट पेन दैट इज इंक्रीजिंग ऑन डीप इंस्पिरेशन और कॉफिंग. ठीक है, तो प्लूराइटिक चेस्ट पेन होगा. साथ में क्या होगा, लंग इन्फेक्शन हो गया है तो हेमोप्सिस हो सकती है और डिस्निया. ठीक है, तो these could be the symptoms that the patient can present with and it very much depends on where the embolus has obstructed the pulmonary artery circulation. तो बेसिकली अगर सेंट्रल पल्मोनरी एम्बोलिज्म है तो डिस्निया, हाइपोटेंशन, शॉक. पेरिफेरल पल्मोनरी एम्बोलिज्म है तो चेस्ट पेन, हेमोप्सिस और डिस्निया. ये क्लासिकल सिम्टम्स है. अब साइंस क्या होंगे, एग्जामिनेशन पे हमें क्या मिलेगा, क्योंकि ऑक्सीजन डाउन है तो रेस्पिरेटरी रेट बढ़ेगा, आउटफ्लो डाउन है तो हार्ट कॉन्ट्रैक्ट ज़्यादा करेगा, हार्ट रेट बढ़ेगा. काफ स्वेलिंग हमें मिल सकती है, ये प्लस माइनस है. अगर पेशेंट को डीप वीनस थ्रोम्बोसिस है लोअर लिम्स में तो लोअर लिम्ब की स्वेलिंग हमें मिल सकती है. ये एक बहुत ही इम्पॉर्टेंट साइन है. इफ़ यू पिक दिस अप your diagnosis of pulmonary embolism becomes very much likely. तो अगर आपको काफ स्वेलिंग मिल रही है तो then that is the sign of DVT and you should get a Doppler done. उसके अलावा आपको BP लो मिलेगा. ठीक है, अनकॉमन क्या क्या है, राइट वेंट्रिकुलर प्रेशर बढ़ने की वजह से JVP रेज मिल सकता है, लाउड P2 मिल सकता है. There could be arrhythmias, डिक्रीज ब्रेथ साउंड. सो जब प्लूरल इन्फ्लेमेशन होता है सेकेंडरी टू पेरिफेरल पीई तो इन रेस्पॉन्स देयर कुड बी प्लूरल एफ्यूजन. अगर प्लूरल एफ्यूजन होगा तो आपको डिक्रीज्ड ब्रेथ साउंड मिल सकता है एंड फीवर. बट माइंड यू ये मैंने अनकॉमन में रखा है, दीज आर नॉट कॉमन. बट वॉट डेफिनेटली यू विल फाइंड ऑन एग्जामिनेशन, टैकिपनिया, टैकिकार्डिया, काफ स्वेलिंग and shock, low blood pressure. So if you find those symptoms and these signs on examination, you should suspect pulmonary embolism. Pulmonary embolism होने के कुछ high risk factors होते हैं जिनमें से जो कॉमन है वो है इमोबिलाइजेशन. तो आपको पूछना है कि पेशेंट की मोबिलिटी कैसी थी, कहीं वो बेड रिडन पेशेंट तो नहीं है, कोई रिसेंट लिम इमोबिलिटी की हिस्ट्री तो नहीं है, जैसे कि कोई फ्रैक्चर हुआ हो या बैक पेन की वजह से पेशेंट मूव ना कर रहा हो, सर्जरी की वजह से पेशेंट मूव ना कर रहा हो. तो आस्क अबाउट हिस्ट्री ऑफ इमोबिलाइजेशन. इनफैक्ट कुछ लोगों को जब लॉन्ग एयर ट्रैवल होता है, जैसे इफ दे ट्रैवल फॉर लाइक 5-6 आवर्स एंड दे सिट इन वन पोजीशन फॉर अ लॉन्ग टाइम, उसके बाद भी पीटी डेवलप हो जाता है. सर्जरी, कोई हिस्ट्री ऑफ ट्रॉमा, प्रेगनेंसी एंड पोस्टपार्टम इज अ हाइपरकोएगुलेबल स्टेट. Any history of previous thromboembolism, very important risk factor. Any history of malignancy. If there is a history of vascular catheter, patient को कोई central line लगी है, कोई femoral line लगी है, femoral artery या femoral venous catheter डला है. So there are some other like antiphospholipid syndrome. This is again a hypercoagulable state. Protein C, protein S, factor V lead-in mutation. These are all genetic causes of thrombophilia. One important history to ask, particularly female patients, is history of hormonal therapy. So if they are taking any OC pills. तो अब हमने देख लिया कि साइंस क्या हो सकते हैं, सिम्टम्स क्या हो सकते हैं, रिस्क फैक्टर्स क्या है, किस टाइप के पेशेंट में हमें सस्पेक्ट करना है, बेड रिडन, एक्टिव मैलिग्नेंसी, रीसेंट सर्जरी, हिस्ट्री ऑफ ट्रॉमा, प्रेगनेंसी, हार्मोनल थेरेपी. सो ये सारे ऐसे पेशेंट्स हैं जिसमें हमें सस्पेक्ट करना है. ऑल्दो pulmonary embolism can occur even in patients who do not have any risk factor, but then the presence of these risk factors increases your likelihood of diagnosis to a much greater extent. ना हमें confirm करना हमारा suspicion. तो अब हम क्या करेंगे? The most definitive test is CT pulmonary angiography. So basically CT pulmonary angiography is just like a CT chest, but उसमें जब हम dye inject करते हैं तो जो dye जब हार्ट और पल्मोनरी वेसल्स के थ्रू ट्रैवल कर रहा होता है, वी टेक द स्कैन्स एट दैट पॉइंट ऑफ टाइम. बेसिकली ये जो डाई है, इट गोज थ्रू द पल्मोनरी आर्टरी एंड हाईलाइट्स द पल्मोनरी आर्टरी. बट जहाँ पे भी ये थ्रोम्बस है, दिस थ्रोम्बस विल बी विजिबल लाइक अ फिलिंग डिफेक्ट. तो यहाँ तक ये डाई नॉर्मली आया था, उसके बाद में ये जो फिलिंग डिफेक्ट दिख रही है, दिस इज थ्रोम्बस. सो दिस कंफर्म्स आवर डायग्नोसिस. सिमिलरली अगर हम यहाँ ध्यान दें इस स्कैन में, तो ये जो कॉन्ट्रास्ट है, ये मेन पल्मोनरी आर्टरी, राइट मेन पल्मोनरी आर्टरी में एक फिलिंग डिफेक्ट को हाईलाइट कर रही है. सो दिस इज राइट पल्मोनरी आर्टरी एम्बोलिज्म. पर सीटी हम तभी ही कर सकते हैं जब हमारा पेशेंट स्टेबल हो. बट अगर पेशेंट शॉक के साथ में आया है या रेस्पिरेटरी डिस्ट्रेस में है, हाइपोक्सिया है, उस टाइम पर हम सीटीपीए नहीं करा सकते. तो वी नीड एंसिलरी टेस्ट टू सपोर्ट आवर सस्पिशन. वो एंसिलरी टेस्ट क्या हो सकते हैं? पहला है डी डाइमर. हम सभी ने ऑर्डर किया होगा डी डाइमर, बट वी डू नॉट अंडरस्टैंड द इम्प्लीकेशंस ऑफ इट. सो डी डाइमर नॉन स्पेसिफिक है. किसी का अगर 10,000 भी आ गया तो आप ये 100% नहीं कह सकते हो कि हाँ इसको पल्मोनरी एम्बोलिज्म है. लेकिन अगर ये 500 से कम आता है तो आप रूल आउट ज़रूर कर सकते हो कि हाँ इसको पल्मोनरी एम्बोलिज्म होने के चांसेस बहुत कम है. सो डी डाइमर इज टेकन एज अ रूल आउट टेस्ट रादर देन अ रूल इन टेस्ट. और हमें डी डाइमर कब कराना है, किस पेशेंट में कराना है, वो हम आगे की स्लाइड्स में देखेंगे. उसके अलावा ईसीजी. ईसीजी में जो मोस्ट कॉमन आपको साइन मिलेगा वो है साइनस टैकीकार्डिया. उसके अलावा आपको S1Q3 T3 पैटर्न भी मिल सकता है, बस ये सिर्फ 10 से 15% में मिलता है. ऑल्दो दिस इज specific. You should look for right heart strain. So right ventricle strain के साइंस देखने हैं. तो जैसे कि हमारा RVH, राइट एक्सिस डेविएशन, राइट बंडल ब्रांच ब्लॉक, ये चेंजेस हमें ढूंढने हैं ECG में. सो दिस कुड बी सपोर्टिव. चेस्ट एक्सरे, 99% ऑफ द केसेस में चेस्ट एक्सरे विल बी नॉर्मल. कभी कभी आपको एक डायलेटेड डिसेंडिंग राइट पल्मोनरी आर्टरी मिल सकती है, जिसे पल्लास साइन या फ्लेशनर साइन भी कहा जाता है. उसके अलावा आपको कभी कभी पेरिफेरल सबप्लूरल एक ओपेसिटी दिख सकती है, वेज शेप्ड ओपेसिटी, जिसे हैम्पटन हम कहते हैं, जो कि लंग के इन्फेक्शन की वजह से डेवलप होता है. सो द फर्स्ट एक्सरे शोज अ पेरिफेरल वेज शेप्ड ओपेसिटी विद ब्रॉड बेस टुवर्ड्स द प्लूरा एंड अपेक्स टुवर्ड्स द हार्ट. सो दिस इज हैम्पटन hump. So this is the CT counterpart of this chest X-ray. There is no dye in the right-sided lobar arteries, and this has caused infarction, lung infarction, distal to the arteries supplied by these lobar arteries. This is manifesting like a wedge-shaped opacity on the X-ray, and this is called as Hampton's hump. Similarly, here we can see that the right pulmonary artery shows a filling defect and is dilated. See how dilated is the right pulmonary artery as compared to the left. So this dilation is visible on the chest X-ray as a prominent descending right pulmonary artery. So this is Palla's sign. Coming to the signs on ECG. So the first ECG shows that there is a negative complex in the lead 1 and positive complex in the lead 3. This is suggestive of right axis deviation. Also we see that there is a positive R more than S, positive complex in V1 along with T wave inversion. So this is suggestive of RVH and right ventricular strain pattern. Apart from that, we can see the most famous S1 Q3 T3 pattern. Here we can see there is a deep S in lead 1, deep Q wave in lead 3 and inverted T wave in lead 3. However, the most common sign is just having an increased heart rate. So you would find in most of the cases just sinus tachycardia. So what could be the differential diagnosis? You are dealing with a patient who has got low BP, low oxygen and increased respiratory rate, increased heart rate. Here your differentials are heart failure, acute MI if the patient also has chest pain, pneumothorax which can also have chest pain plus all of these, or pneumonia. So these are your differential diagnoses when you are dealing with a patient of pulmonary embolism. So obviously when you have heart failure you will hear Krebs on auscultation and you will have something like a cardiomegaly with bilateral battering appearance. When you have MI, you will have the ECG changes that are suggestive of MI, that is the ST elevation or ST depression. In pneumothorax, you are going to have a silent lung on auscultation and you will have something like a hyperlucency with a collapsed lung on the side of pneumothorax. In pneumonia, you are going to have fever, leukocytosis plus something like a patch. So we used to have a very simple dictum. If the patient has hypoxia and your chest X-ray is normal, go for pulmonary vessel imaging. Now we are always in a dilemma whether we should go forward with a CTPA or not. And there are many reasons to it. CTPA is not a cheap test. Firstly, you will be exposing patient to radiation, there is a risk of contrast allergy, contrast nephropathy, plus it comes with a cost. And so we need to decide how sure or how probable is our clinical suspicion for PE so that we can with confidence prescribe CTPA. So how do we do that? For that we have few scores which help us decide the likelihood, the pre-test probability of pulmonary embolism, and the most famous one we all know is the Wells criteria. So if you find DVT or if you feel that there is no other alternative explanation other than pulmonary embolism, they score the highest in the scoring with a score of 3 each. Apart from that, if you find tachycardia or there is history of immobilization for more than 3 days or surgery in the previous 4 weeks, that scores 1.5 each. Along with a history of previous DVT or pulmonary embolism, that scores 1.5. So patient who has got a previous DVT or a pulmonary embolism is at a higher risk later on to develop recurrence. So here we see that the most strong points are given to if you clinically think there is no other reason for pulmonary embolism or if you find DVT. Next comes tachycardia, history of immobilization or surgery, or a history of previous DVT or PE. Next is hemoptysis and malignancy. Now there are 2 ways of scoring it. Either you can score it as high, moderate or low, that is the Wells criteria, or you can score it as PE likely or unlikely, that is modified Wells criteria. So anything score which is less than 2 is low, 2 to 6 is intermediate, and more than 6 is high. Here they have included age as one additional risk factor. Apart from that, they have also given priority to previous history of DVT or pulmonary embolism, history of surgery or fracture, active malignancy. They have included symptoms and signs separately here. So hemopsis or unilateral lower limb pain has been given under symptoms, and signs include a heart rate of more than 75 to 94 or more than 95, along with pain on lower limb, palpation or unilateral edema. So when you compare the Wells criteria and the modified Geneva criteria, what all things are not there? So PE more likely than other diagnoses is not included in the Geneva criteria, and apart from that you find everything included over here. In the modified Geneva criteria, they have taken age as an extra factor. Apart from that, they have divided heart rate into two categories, 75 to 94 or more than 94. And here, symptom of DVT and sign of DVT have been taken separately. So if there is a history of unilateral lower limb pain, that is given a separate scoring. And if on examination you find pain while on palpation of the lower limb, that is given a separate finding. And apart from that, a previous history of DVT, that has been given a scoring separately. So you need not remember the numbers, but it's important to remember the constituents of the scoring. Important here to note is that they have not included SpO2 or D-dimer in any of the scoring. So this is very important. Now there is also something called as pulmonary embolism rule out criteria. So there are these 8 points. If your patient doesn't have any one of these 8 findings, then you can easily rule out pulmonary embolism. So what are those? If your patient is younger than 50 years, does not have tachycardia, has a normal oxygenation, there is no hemopsis, no prior DVT or PE, no history of hormonal use, no unilateral leg swelling, no history of immobilization due to surgery or trauma in the prior 4 weeks. If none of these factors are present, then you can rule out pulmonary embolism, and we will see how this helps us, where this PER criteria comes into use. So now you have examined the patient, you have calculated the Wells criteria and it is less than 2. So now before ruling out pulmonary embolism completely, you need to check the PER criteria. So is any of the following factors present? If any of the following factor is present, then you go for D-dimer testing. If it is more than 500, then you need to do CTPA. But if D-dimer is less than 500, as we learned in the previous slide, we can rule out pulmonary embolism and P is out of your differential diagnosis. Now, if your scoring is coming in the intermediate level, that is between 2 to 6, then what do you do? Here you don't apply the PER criteria, you directly go for D-dimer testing. So the role of PER criteria is only in OPD based patients who are not yet hospitalized and you have low probability of PE. Here in the intermediate probability of PE, you directly go for D-dimer testing. If the D-dimer is more than 500, you do a CTPA and then confirm your diagnosis. However, if the D-dimer is less than 500, then you can exclude pulmonary embolism. It's as simple. Now, if you have high probability of PE, that is the scoring is more than 6, in that case you directly go for CTPA. You don't need a PER criteria, you don't need a D-dimer testing. You directly go for CTPA if feasible and confirm or rule out your diagnosis. So, what are the indications? Just as we saw, first is high probability. A Wells score of more than 6, directly go for CTPA. Low probability, if any one of the PER criteria is positive and D-dimer is more than 500, go for CTPA. Intermediate probability of PE, go for D-dimer testing, and if more than 500, go for CTPA. So these are the indications of doing CTPA in a patient in whom you suspect pulmonary embolism. Now we will apply everything that we have learnt till now with a case. few days back, a patient presented to me. He was 65 years old and he had a sudden onset shortness of breath. So he said, "Doctor, I'm traveling every day. I'm walking around 4 to 5 kilometers. I'm very physically active." He's a non-smoker, never had any issue, no diabetes, no hypertension, and I've suddenly started to feel out of breath. His room air saturation was 85%, his heart rate was 120, his BP was 120/80. That's the case profile. And his ECG showed us tachycardia. This was his chest X-ray. So as we know, we have learned the dictum, patient is hypoxic and there is nothing on the lung parenchyma. So focus on the vessels. So now whether or not I should do a CTPA, for that I need to see the well scoring. So my patient does not have a clinical symptoms or signs of DVT. He does have a heart rate of more than 100. There is no history of immobilization, previous DVT, hemoptysis, malignancy. For my patient, because he is hypoxic and there is nothing on the chest X-ray parenchyma, so I do feel that there is no other likely diagnosis other than P that I can offer. So his scoring comes to 3 and 1.5, which places him in intermediate probability for pulmonary embolism. Here we did the D-dimer and the D-dimer of the patient was 1500. So we went forward with CTPA in our patient and this is what we found. So basically there was a filling defect in the right pulmonary artery as well as in the left pulmonary artery, which was going into the lobar segments as well. Here we can see the filling defect in the right pulmonary artery and the left lobar arteries. So this confirmed our diagnosis of pulmonary embolism. So this was the report that we got, which said that there was filling defect in the right main pulmonary artery, completely occluding the distal part of the right pulmonary artery, extending into the right upper lobe and right lower lobe. Also there was partial filling defect in the left pulmonary artery. So this confirmed our diagnosis of pulmonary embolism. How do we approach this patient? How do we treat him? What is the management? For that, please follow this channel and stay tuned for part 2, where I focus on the management of pulmonary embolism. See you there.